Hi and welcome to the last part of this session where we will cover the lower extremities projection that consists of foot, ankle, tip feet, knee and femur. First, in epifoot, any rotation will cause the medial and intermediate cuneiform joint space to be closed. Moreover, you can also evaluate the position of navicular tuberosity and the superimposition of tala with calcaneus. As usual, in oblique projection, you need to check for its accuracy of obliquity. In a sufficient angle of oblique foot, the cuneiform cuboid joint space should be open. The first and second metatarsal joints are closed, while the third to fifth metatarsal joints are open. To detect whether the foot is under rotation or over rotation, check for the fourth metatarsal tuberosal superimposition with the fifth proximal metatarsal. Second is ankle. The medial mortise must be open in epi-ankle projection. Then, evaluate the tibia and talus superimposition of the fibula. If there is little or no superimposition, the ankle is internally rotated. If the medial mortise is closed, the ankle is externally rotated. Radiographer should detect rotation and parallelity in the lateral ankle. Evaluate the position of fibula on the tibia to detect any rotation. When the forefoot is elevated, the medial taladome is posterior to the lateral taladome. And when the forefoot is depressed, the medial taladome is anterior to the lateral taladome. The position of taladome also can be used to detect the ankle parallelity. Additionally, the superimposition of the navicular cuboid also can determine the parallelity as described in the slide. Third is tibia-fibula projection. Evaluate the relationship of tibia and fibula to detect any rotation. In the internal rotation of tip feet, the head of fibula is away from tibia, while the base of fibula is away from talus. However, in external rotation, the fibula is located beneath the tibia, closing the medial mortise. Similarly, the position of tibia and fibula can also be used to detect rotation in lateral tip feet as described in the slide. Fourth is knee. Firstly, evaluate the size of femoral condyle. The external rotation demonstrates a larger medial condyle compared to lateral condyle. Meanwhile, internal rotation demonstrates a larger lateral condyle. Next, evaluate the relationship between fibula head and tibia. If the fibula is superimposed by the tibia, it is external rotation. However, if there is very little superimposition, it is internal rotation. Furthermore, you could detect poor central ray angulation by evaluating the shape of the fibula head and its proximity to the tibial plateau as explained in the slide. There is a way to distinguish the medial and lateral condyles in the lateral knee. Referring to the image, the lateral condyle is typically flat, while the medial condyle is convex. To determine whether it is a true lateral or not, evaluate the femoral joint space and the surface of medial and lateral condyles. The femoral joint space should be open. The medial and lateral condyles should be superimposed. If the knee is flexed more than 20 degrees, the patellofemoral joint space will be closed. Lastly, femur. In epidistal femur, the femoral condyles are evaluated to determine any rotation, similar to epi-knee. However, in epiproximal femur, radiographer can evaluate the relationship of ischial spine and pelvic brim, and also the visualization of obturator foramen. Meanwhile, the visualization of the femoral neck can determine the leg and foot rotation. In external rotation, the femoral neck is foreshortened and the lesser trochanter is in profile. In internal rotation, the femoral neck is without foreshortening while the greater trochanter is in profile. For a true lateral femur, the medial and lateral femoral condyles should be aligned and a portion of fibula head is beneath the tibia. In external rotation, the medial condyle is anterior to the lateral condyle. Conversely, in internal rotation, the medial condyle is posterior to the lateral condyle.